Naples, Parthenope, Italy. She specializes in computer vision, machine learning, and biometric systems with a strong publication record and active research collaborations in AI and visual computing. Her academic and professional work focuses on developing computer vision and machine learning techniques for practical applications, including biometric identification, emotion recognition, multi-modal interface, and AI system in healthcare and human computer interactions. Ma'am, I feel immense pleasure to please welcome you to start the session.
Thank you, Akanksha. So for your information, I can tell you with Dr. Paola, I am working with Dr. Paola for the last 3 to 4 years. Am I right, Dr. Paola? I think 3 years
Yes.
minimum. Yeah. So thank you for accepting our request. And definitely in this winter school, we are trying to do something different. So we'll be in contact after the winter school also to do something with the students. So thank you. Now your session is yours. Yeah.
Thank you for inviting me again also this year. I would like to share my screen.
Yeah, you can share. Yeah.
Okay, you can see my presentation?
Yes.
Okay. Okay, good morning. Today, I hope that later my colleague Luigi Di Biasi will join us, but he had some trouble at home. Maybe he will not join us. But anyway, we will present deep learning for biomedical signals and medical imaging from critical. Sorry, I want to. My image. Allora. No, there are. Okay, sorry. Okay.
Yes, now it's okay.
Okay. From clinical time series to image-based decision support. I will present many approaches we used in medical images. The image in a clinical settings where decision must be made fast with incomplete information and where the data are increasingly complex. Hundreds of MRI slices, long physiological recordings, heterogeneous devices, and protocols. So let's take a look to the agenda. This session will introduce practical deep learning methods for biomedical data analysis, and we will cover both physiological time series and medical images. We will focus on clinical time series and biomedical signals, such as continuous monitoring data and other physiological measures, discussing how convolution and sequence models can be used to model patient trajectory, support area risk prediction, and integrate with other critical information. So we also show how image classification segmentation support clinical decision making across medical specialties, and we will highlight common challenges, how we approaches to these challenges, such as data quality, class imbalance, real-world evaluation, and model interpretability. In medical AI, errors are not symmetric. A false negative can mean missed cancer or missed arrhythmia. A false positive can mean extra tests and anxiety, but the clinical cost is often different. That asymmetry changes everything: model selection, threshold, metrics, and how results should be communicated. Trust is not a marketing word here. It is the practical question. Can a clinician rely on this tool on a bad time? with a new scanner in a new hospital with a different patient population. That is why we keep returning to robustness and explainability. So, why trust is critical in care? Of course, because the decision impacted the diagnosis, treatment, resources allocation. There are errors and bias that can be systematically that can harm vulnerable patient group, for example. And the patient must understand and accept AI support decision, and also loss of trust can damage the doctor patient relation and the institution. So the AI says, don't hospitalize. Would you trust it? When we talk about the AI, the first thing we usually ask is how accurate is the model? But in clinical practice, that's not enough. If a model has 90% of accuracy on a paper, but nobody trusts it enough to use it on a patient, this is worthless. This effectively worth zero. So, uh, okay, sorry. The real question is not just does it work, but with the AI, our question is how it works. Can we trust how it works? And in the most of cases, we don't trust it. There are three pillars for the high risk system, such as a medical one: lawful, ethical, and robust. Lawful, the system must comply with GDPR and the AI Act. Ethical, the system must not discriminate, and we know that there are so many bias, so the system could discriminate the classification. And the robustness, the system must not break down as soon as the data change a bit. It must be resistant to noise and measurement errors, and it must remain safe even under imperfect conditions. So that is in the real world. So the primary requirements for high-risk system are the precision and accuracy, so the high performances, then documentation and validation. We need it for the data validation and limitations, and also audit and incident investigation. So post hoc analysis, root case analysis, regularity, compliance, accountability, and governance. And finally, the clinical explainability for the audits and the, of course, incident investigation. So also support for judgment, risk communication, patient safety, and trust. We need explainable AI because we must gain trust. Explainable AI, of course, explain us how to trust and why we need to trust. So we must gain trust across multiple stakeholders in the biomedical analysis. There are, of course, clinicians, patients, data scientists, because we want to debug the models, institutional regulation, because we want safety evidence. How we can gain trust? There are black boxes model that reduce trustworthiness. Explainability may improve transparency and accountability and safe human AI collaboration. how XAI supports trustworthy AI. It helps validating clinical plausibility. So in these images, for example, we can see the explanation of the diagnosis with the use of AI. So if the, for example, if the classification is true or false, the explanation of the classification can indeed explain us why the classification is done. How we can gain trust? How XAI supports trustworthy AI? It allows and supports human oversight. So first of all, we have the examination by a radiologist. Then we have the dataset with the sequences of the images and also database about AI data detection with the remote tracker. We analyze and overlap images, and then an AI module train an agent as an expert radiologist, and there is a feedback of the unobserved zones. Then the human of the loop do the validation, the final validation. Across modalities, the workflow is remarkably stable. Start from data, decide what preprocessing is clinically acceptable, train a model, evaluate it with clinically meaningful metrics, and then connect the output to a human decision. There is the human in the loop. Explainability and human in the loop are not add-on. They are the interface between an algorithm and a clinical workflow. The pipeline is the thread that connects everything we will discuss. Gaze support in radiology, melanoma classification, time-lapse embryo assessment, and EEG anomaly detection. So let's talk about the first scenario. Then I will explain some studies we have done. This is the first one. One practical idea is to support attention rather than replace judgment. If we can model how experts explore an image, what they check, what they revisit, we can design feedback that nudges a reader when a region might be underexplored without dictating the diagnosis. This shift decision support from predicted label to improve the process, reduce blind spot, reduce missed regions, reduce fatigue-driven failure models, and keep it concept in mind, because later, when we talk about heat maps and EEG segments, we will again be using explanation as a way to keep the human in control. So first of all, here we will talk about the focus gaze DX, a real-time AI tracking framework from our radiological image analysis. Oh, if this image, I can show it. Okay. How many of you have seen have tried to read a brain MRI? If you want to try, you have to see hundreds of slices where are also labeled and catch the most minor details. Here, for example,
image that's
okay.
sagittal. So here
I show this
nose, here is the back of the head. That's very clear. And on these sequences, the multiple sclerosis plaques can be seen fairly obviously. So if we start in the middle and go to either side, you'll see some classic examples. One is this area here. So you can see that plaque there is a bright perpendicular oriented plaque. Here's another one here that again is perpendicularly oriented towards the corpus callosum. And as we move to either side, there will be other lesions that can be identified. Here's another classic one. Again, the orientation of the plaque being perpendicular or at right angles against the corpus callosum, this midline structure, often identify it as a demyelinating-like lesion or multiple sclerosis lesion. And here's another one here. And again, perpendicularly oriented lesions, especially against the central structures such as the corpus callosum, are often seen in multiple sclerosis patients. Another classic lesion can be seen here. This area here is something we see, and often people refer to it as juxtacortical because it's between the cortical gyri on top. And if we look at other sequences,
so we should see so many slices of images, 100 of slices, and we have to catch with our eyes the most minor details. And we trust the clinicians, but this is not easy, and often they have to do it in the night or under pressure. But we trust the clinician. Anyway, we don't trust the AI, but we trust the clinicians. So let's start for the medical reasons. When the myelin is damaged, communication between the brain and the rest of the body slow down or stop, leading to moderate cognitive impairment. And the multiple sclerosis, we can summarize it in the 3 lines. The immune system attacks itself. Early detection can preserve function and slow the progression. And error in the diagnosis delay care and might cause unnecessary treatments. So the improving the diagnosis accuracy in the multiple sclerosis is not just a research goal, but it is a medical need. How challenging is multiple sclerosis diagnosis? The symptoms can vary widely. The lesions can be small or ambiguous, and sometimes lesions mimic other conditions, so we can misunderstand the symptoms. Radiologists must interpret dozens or even hundreds of images, integrating anatomical, temporal, and clinical information simultaneously. And that's why we have errors, and that's why we can use the AI to help us in diagnosis. We are not talking about delegate this role to the AI, but we can use it as a tool. So it is challenging, not because of lack of skill, but because it must be done by humans, and humans can be tired, and also can misunderstand some images. No one can maintain perfect focus for hours, also maybe in the night, and the concentration can fade. Even for experienced clinician, it is not right. It is not easy. So the medical imaging is visually demanding for reasons that rarely appear in benchmark papers. There are large volumes, many slices, subtle findings, and time pressure. There is cognitive load and fatigue, and there are not noise. There are conditions under which real diagnosis happened. So studies report around a 30% retrospective errors rate in the radiology and about 3 to 5 percentage in daily practice. These errors often come from perceptual misses, cognitive overload, or systemic factors such as fatigue and time pressure. So instead of trying to replace humans with automation, we ask ourselves, what if technology could help experts stay focused and consistent? So the challenge is how to support human attention in one of the most demanding cognitive tasks in medicine. And so we are talking about support human attention, not to substitute it. Our mission, so we don't want to replace the human expertise. Again, we want to support it. Instead, so we want to make it safer. We aim to understand how experts assess images. We want to provide feedback when something may have been overlooked. So our hypothesis idea, the first one is the eye movement and gaze play a crucial role in the multiple sclerosis diagnosis. And second one is if we track eye movements, we can actually see the path of attention where experts look, how long they stay, and what they skip. The experienced radiologist exhibit structured and efficient gaze patterns. Less experienced readers often jump around more. Can we exploit it? What if technology could help experts stay focused and consistent? Our solution, our proposed solution is this approach add an extra layer of safety and consistency, especially during long session or under heavy workload. By analyzing and modeling these visual behaviors, we can design systems that gently guide attention toward the most relevant regions without interfering with professional judgment. So a computer-aided analysis and a diagnosis system can help physicians to verify wherever they have examined the correct areas or if they have missed something. If they have missed something, it guides attention toward the most relevant regions. It not decide. It helps. Don't want to substitute to replace. So we can think of it that the eyes of a computer-aided diagnosis system never can get tired. While the radiologist reads the exams, the eye tracker records data in real time. This information is processed through a reinforcement learning model trained on an expert behavior. If certain areas remain under-examined, the system provides subtle visual feedback. A small highlight or contour suggests a quick recheck. No alarms, no interruptions, just a quiet companion helping to keep attention where it's needed. The interface is minimal, with colored contours marking only those regions that deserve a second look. It allowed radiologists to revisit potentially missed areas quickly and confidentially without slowing the reading process. So here we can see again that why we are looking for the problem, our system can show if we missed something, and we can annotate it. Okay. So the focus gaze DX combines eye tracking data and reinforcement learning to support radiologists in image analysis. It detects and flags underexplored regions in real time through expert gaze, modeling, and visual feedback. It is in clinical validation study in collaboration with the University San Raffaele of Milan, focusing on MRI reading for multiple sclerosis, modular and adaptable across imaging modalities, through current validation focuses of MRI for multiple sclerosis. May enhances rather than replaces human decision making via a human in the loop system, and may improve diagnosis accuracy, efficiency, and confidence, especially under fatigue or high workflow. So the summary of the technique are the convolutional neural network, recasting, and human in the loop. So symbiotic AI. Now we can see a different imaging problem. Dermoscopic images for melanoma detection. In this analysis, how deep learning can help medical imaging analysis. This is an hybrid approach for the design of CNN using a genetic algorithm for melanoma classification. Skin cancer is one of the most common cancers worldwide, and it includes several different diseases with very different level of risks. Melanoma is not the most frequent type, but it is responsible for a large share of skin cancer related deaths because it can progress and metastasize quickly. For the reason, timing matters. When melanoma is detected early, treatment is often highly effective, while delays can have seriously consequences. So we introduce Mela in clinic melanoma detection human-based approach. In clinical practice, dermoscopic images is widely used to support visual assessment of skin lesions, but diagnosis is still challenging. Lesions can look similar across benign and malignant cases. Image quality and acquisition condition can vary, and there is meaningfully variability even among experienced clinicians. This is exactly the kind of setting where AI-based decision support can be useful, not as a replacement for medical judgment, but as a tool that can help prioritize risk, reduce missed cases, and provide additional evidence that can be inspected and discussed. So, computer-aided diagnosis systems for skin cancer are typically built around the convolutional neural network, even because we are analyzing images. The convolutional network are well suited indeed for image-based pattern recognition. In this setting, a CNN takes a dermoscopic image as an input and learns hierarchical visual features, ranging from low-level texture and color patterns to high-level lesion structure that are relevant for discrimination between benign and malignant cases. In practice, there are systems follow a relatively standard pipeline: image preprocessing and normalization, future feature learning through a CNN, often initialized via transfer learning, and final classification stage that produces a risk score The output of the model is not a diagnosis, but a quantitative assessment that can support clinical decision making, for example, by flagging high risk lesions for future examinations. So there are the performance of CAD system that often look impressive on a specific dataset. And then degrade when something changes: acquisition protocol, devices, illumination, population, annotation habits. This is domain shift in practice. It is why training score is not a clinical guarantee. So when we evaluate a melanoma model, the real question is, does it keep behaving when condition changes? And if it fails, how does it fail? That naturally leads to two strategies: architecture choices that may generalize better, and evaluation practice that reveal brittleness. So the very first question we had was, do we trust AI and CAD? At this point, this is important to highlight that computer-aided diagnosis systems are not free from critical limitations. A well-known example comes from ISIC skin lesion challenges, ISIC challenge of 2019. The winning algorithm in the 2018 showed an impressive accuracy of 88.5%. However, when evaluated in the ISIC 2019 challenges, the performance dropped dramatically to 63.6%. What is striking in that is that this drop was due to a flawed model, but simply to a more realistic scenario: more classes, more images, and higher variability. This clearly shows that many CAD systems are extremely sensitive to dataset shift and lack robustness. That was one of the very first limit we wanted to avoid, the lack of robustness. In clinical practice, this is dangerous. A system that performs well in controlled benchmark may fail when deployed in real hospitals. This is why accuracy alone is not enough to claim clinical usefulness. So, what we want to do? One way to reduce manual bias in architecture design is to automate exploration. A genetic algorithm treats a network design as a genome. Layers and hyperparameters become the genes, and evolution selects architecture that performs better under the chosen fitness criterion. The interesting part is not the metaphor. The interesting part is the control you get. You can encode the constraints and the objectives, and you can search systematically rather than by intuition. This is a tool, not a default choice, because it trades compute for potentially better design. So this is where engineers' reality matters. Architecture search to in search the architectural search is expensive, so it can often overfit the validation protocol if the protocol is weak. It can optimize the wrong objective if the objective is not clinically aligned. So the practical question becomes, when is this worth it? Typically, when you have a stable pipeline, enough compute, and a clear target objective aligned with the critical priorities. For the hands-on, we will not turn, we will not run into a genetic algorithm. We will do a baseline model and we will focus on what really controls trust. So metrics, threshold, and explanations. So here is, we show the core operation of genetic algorithm. As in a natural evolution, we apply selection, crossover, mutation, and then we merge operations. Standard genetic algorithm operations are responsible for preventing high performing individuals, while extended operation allows us to introduce diversity and avoid premature convergence. This evaluation process enables continuous exploration while retaining the best performing architecture across generations. Each gene represents a specific architectural or hyperparameter choice within the neural network. By encoding the CNN design decision as genes, we can evolve not just weights, but the structure of the network itself. This is crucial because we are not assuming a priori which architecture is optimal for the task. So you are using a genetic algorithm to create and extract the optimal architecture for the convolutional neural network. I'm sorry if some slides in my PowerPoint are messed up. I don't know what happened. Anyway, we use the maximization of the global population accuracy and as the function to drive the population evolution. For each evolutionary step, we computed the maximum accuracy from each survived entity. Thus, for each generation, all the entity that exposes an accuracy and time t equals or better than the previous generation t minus 1 maximus accuracy will survive. Also, a random 10% of entities were chosen in each step to survive independently regarding the accuracy at time t. And finally, if no accuracy improvement was detected for 10 consecutive evolution steps, the genetic algorithm was stopped. Due to the physical limits of this cloud platform, of our cloud platform, we were forced to limit the possible crossover and mutation. As the result, only 10 mutation and 100 crossovers were allowed for each survived entity. We tried to mitigate this constraint with with an initial randomized population of 10,000 of entities. Then we forced the evaluation to stop after 100 iterations. Ah, okay, this is the table, okay. Okay, the scoring function is the key driven of evolution. Accuracy is used as the main fitness criterion. Sorry. Okay, so only the top performing individuals survive, while a small percentage is preserved regardless of performance of maintaining diversity. If no global improvement is detected after a fixed number of evolutions, the system stops automatically. Importantly, we already anticipated the next step, minimizing false negatives, which is far more relevant than raw accuracy in medical applications. These slides illustrate the distributed architecture used to evaluate the evolving population. Training multiple neural network is computationally expensive, so we rely on parallel execution to speed up the evolution process. Each candidate model is trained and evaluated independently before selection. Oh, forse ho sbagliato. So here we show preliminary results illustrating how accuracy evolves over generations. As expected, the system progressively converges toward better performing architectures. These results confirm that evolutionary strategy is effective in navigating the architectural search space. Okay. Despite promising results, this approach has limitations. A large amount of computational time is wasted to a high death ratio in the population. Large populations require significant computational resources, and each training run incurs overhead for data preparation and normalization. In our experiment, this was particularly evident due to use of MATLAB. Okay, this is a filter approach. We use AI and biomedical signals, so continuous signals like the time series, ECG, EEG, and so forth. In this study about identification of morphological patterns for the detection of premature ventricular contractions. ECG is a different modularity, but the decision support story remains the same. Signals are temporal, often noisy with events that matter locally, and with large patients to patients variability. In imaging, domain shift domain shift is hospitals and devices. In signals, shift is often patient and physiology. So the same pipeline applies, but the representation changes sequences instead of pixels in this case. So we have signals and we don't have images. But let's start from the beginning. The heart is a muscle divided into 4 heart chambers, which beats and continuously pumps blood to the rest of the body. The upper chamber are the upper chambers. Okay, here. Oh, ecco qua. The upper chambers are the others, while the lower ones are the ventricles. The heartbeat is the rhythmic contraction of the fourth chamber and is stimulated by electrical impulses tracked and recorded by the ECG. The cardiac electrical impulse starts from the upper right chamber, braces into the left atrium, causing it to contract and pushing the blood into the lower chambers. The ventricles contract and pump blood into the lungs and body. The system acts as the body's natural pacemaker and keeps the heart rate as a normal value of 60-100 beats per minute. If the system's activity is interrupted to the heart damage or another pathology, the heartbeat may assume an abnormal rate or an irregular rhythm. This can affect blood flow to the brain and other organs. The cardiovascular diseases are the leading cause of death worldwide, accounting for 32% of all deaths. Most of the deaths occur in low and middle income countries. This emphasizes the importance of early detection and scalable diagnosis tools. So here we can see that the millions of fatalities annually and are caused by the cardiovascular diseases. The electrocardiogram is the primary tool for measuring the electric activity of the heart. It is not invasive, widely available, and extremely informative, but also complex to interpret. Why is important to detect and classify anomalies? Detecting anomalies is crucial because not all irregular heartbeats are equally dangerous. Some are benign, while others may indicate life-threatening conditions. So the cardiovascular diseases are the leading cause of death globally, and 17.9 million people died from cardiovascular diseases in 2019, representing 32% of all global deaths. Of these deaths, 85% were due to heart attack and stroke. Over three-quarters on the cardiovascular diseases death take places in low and middle income countries. Out of 17 million premature deaths under the age of 70 due to non-communicable disease in 2019, 38% were caused by cardiovascular diseases. Most cardiovascular disease can be prevented by addressing behavioral risk factors such as tobacco use, unhealthy diet, obesity, physical inactivity, and harmful use of alcohol. It is important to detect cardiovascular diseases as early as possible so that management with counseling and medicine are begin. And also, cardiovascular diseases are genetical are genetic diseases. So the risk factors that we can prevent are caffeine, alcohol, tobacco, anxiety, stimulant drugs such as methamphetamines, and heart disease. So certain lifestyle choices and health conditions may make a person more likely to develop premature ventricular contractions. Having frequent premature ventricular contractions or certain patterns of them might increase the risk of developing irregular heart rhythms, arrhythmia, or weakening of heart muscle, they're named cardiomyopathy, myopathy. Rarely, when accompanied by heart diseases, frequent premature contractions can lead to chaotic, dangerous heart rhythms and possibly sudden cardiac death. PVC, that this is the acronym of premature ventricular contractions, are clinically relevant event that may be intermittent and easy to miss in the long recordings. The detection problem is not only is there a PVC, but also where is the PVC, and is the evidence interpretable for a clinician? That connects directly to the decision support team. Models should not just output labels, they should point to the evidence within the trace. In a typical heart, this signaling process usually goes smoothly, resulting in a resting heart rate of 60 to 100 beats a minute. PVC are irregular contractions that start in the ventricles instead of the atria. The contractions usually beat sooner than the next expected heartbeat. The cause of the premature ventricular contractions isn't always clear. Certain things, including heart disease of changes in the body, can make cells in the lower heart chamber electrically unstable. Uh, sorry. Okay, I use this slide because, okay. So PVC originates in the ventricles and occur early than expected in the cardiac cycle. They can be harmless, but in some cases they signals underlying heart disease. The challenge is not just detecting the PVCs, but classifying their severity and understanding their morphological patterns. It is important to stress that there is not just one type of heartbeat anomaly. There are multiple classes of anomalies, and each class may include several subclasses with different clinical implications. This diversity makes automated detection particularly challenging because models must generalize across many patterns rather than learn a single signature. Okay. Oh, no, 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 no. Oh, mamma, che è successo? Oh, mamma. Mm, sorry, 55. Okay, we are here. Okay. In this presentation, we focus specifically on, on PVCs that often affect the QRS portion of the cardiac cycle, altering its morphology and timing. Even though PVCs are common, they may belong to different classes, harmless, potentially dangerous, or even lethal. This motivated the need for detecting classification and pattern recognition rather than binary decisions. Okay, PVC are often benign and may not require treatment. However, in some cases, they are associated with serious underlying conditions such as cardiomyopathy, heart failure, or coronary artery disease. Being able to distinguish dangerous PVC patterns from harmless ones could allow CAD system to support clinicians and potentially save lives. One first approach treats ECG signals as images. We start from the MIT BAIH arrhythmia database and apply images preprocessing to ECG waveforms. By comparing ECG wave images and computing distance matrices, we aim to identify similarities and differences between PVC and non-PVC patterns. We use the MIT BIH arrhythmia database, which contains half-hour ECG recordings from 47 subjects. From these recordings, we generated RGB images representing the ECG waves. We built multiple databases of increasing size, balancing PVC and non-PVC samples to avoid bias during analysis. Our working hypothesis is that non-PVC ECG signals may include multiple talent arrhythmia patterns that are not labeled explicitly. The main challenge is identifying common patterns within this heterogeneous class. Understanding these patterns could improve both classification performance and clinical interpretability. So the images are attributable to different arrhythmia and non-PVC classes. However, we do not know this intra-class difference a priori. The challenge is to associate the main challenge associated with the detection of PVC is to identify common patterns. The preprocessing pipeline consists of three main steps. There are noise removal, ECG wave extraction, and conversion to binary images. These allow us to standardize the data and focus on morphological differences rather than the raw signal noise. Each binary ECG image is represented as a matrix. We compare pairs of ECG waves by computing multiple bounding boxes and analyzing a gradient within each region. This fine graded comparison captures local morphological variation between heartbeats. To quantify similarity between ECG images, we compute distance matrices using multiple metrics. These include the mean squared error, structural similarity index, and gradient magnitude. Each matrix captures a different aspect of similarity, from pixel level differences to structural changes. So the mean square errors, a lower mean square errors value indicates greater similarity between X and Y. The gradient magnitude is defined as a directional changes in image intensity. Applying these operators for each subdistance, the structural similarity and pixel high interdependencies, particularly when they are partially close one to other. So we apply this operator for evaluating the distances. Once the distance metrics are computing, we apply k-means clustering to explore latent structure in the data. The elbow method of Davis-Baldwin index help us select the optimal number of clusters. The step is exploratory, aiming to reveal a hidden pattern, then perform final classification. So the optimal number of cluster is 4. Here we can visualize how ECG samples cluster under different dataset sizes. As the dataset grows, cluster structure become more evident, suggesting the presence of consistent patterns. However, the interpretation remains challenging without clinical labels. So we can see larger is the dataset and easier is the clustering. This approach is still experimental and limited by dataset size. While clustering reveals promising structures, we cannot yet associate them with specific clinical meanings. Nevertheless, the results suggest the existence of latent pattern worth further investigation. For the same problem, in the second approach, we move from image similarity to sequence modeling. Here, the focus is on learning temporal patterns directly from ECG signals using neural networks. ECG is a different modality, but the decision support story remains the same. Signals are temporal, often noisy, with events that matter locally, and with large patient-to-patient variability. In imaging domain, shift in hospitals and devices, in signals, shift is often patient physiology. So the same pipeline applies, but the representation changes the sequences instead of pixels. So in this second approach, what we are trying to do, the key idea is to train our recurrent neural network only on healthy heartbeats. A well-trained model should accurately predict healthy ECG pattern. When exposed unhealthy signals, the prediction error should increase, revealing anomalies. So our hypothesis is that healthy heartbeats follow predictable temporal dynamics. PVC disrupt this pattern, causing the model to fail when predicting future signal segments. This failure is quantified using the RMSE, the minimum squared error, which becomes a proxy for anomaly detection. So we have a well-trained RNN to healthy data. So our well-trained RNN on healthy heartbeats dataset will expose a low error rate when used to predict the trend to another healthy heartbeat signals. A well-trained RNN only on a healthy heartbeat signals will fail to predict our unhealthy heartbeat to expose high RMSE. So this is the working hypothesis is the PVC usually disrupt EEG normal patterns. Therefore, an RNN trained on a dataset composed of LTQRS will expose with high RMS when used to predict of an unhealthy heartbeat. We again rely on the MIT BIH dataset. So as we have seen, it comprises 47 subjects of ECG acquisition. Each acquisition comprises 48 half-hour ECG recordings extracted from two channels ECG. Each acquisition is manually annotated by experts and classified in PVC or not PVC. This dataset contains up to 7,000 samples of class PVC and up to 40,000 samples of class not PVC. We balance the dataset in this work. All the annotation in the dataset are relied to medical experts. So there are the temporal signals. Then we split the data in three subsets, of course, training set, validation set, and test set. Why this division? The dataset is already split into training, validation, and test. Importantly, the RNN is trained only on non-PVC data. This ensures that the model has no prior knowledge of unhealthy patterns. One major challenge is that we do not know in advance which RNN architecture is optimal. Manual architecture design will be inefficient and potentially suboptimal. Our solution to address this, we use extended genetic algorithm to automatically design the RNN architecture. The genetic algorithm explores different configurations and selects those that best model healthy ECG signals. So we improved the extended genetic algorithm approach, and we developed starting from 2021 to allow EGA to design for us the RNN structure driven by accuracy as a scoring function. So the same approach we have had for the images, we use for the signals. So genetic algorithms replicate how Darwinian evolution seems to allow the survival of the organisms that best adapt to the environment. In standard genetic algorithms, a population P of artificial organisms evolve over time using techniques similar to the natural evolutionary processes. How we apply classic genetic algorithm principle is each entity represents a candidate network composite of residual layers. Through selection, crossover, and mutation, the population evolves toward better solutions. At the time, the population P is composed by one or more entities, like living organisms. The entity expresses behavior related to its genome. Each genome contains one or more chromosomes, and each chromosome comprises one or more locus, a specific location on a chromosome. An entity may express or not behavior at time t. In this study, a behavior is a residual network layer with its own hyperparameter configuration that can be possessed by an entity. So in MATLAB, we prepare the initial population Then we performing genetic algorithm operations on the population. Then we distribute population across GRI-MD. So we train multiple recurrent neural network, and then we reduce it to selecting a survivor entities. The two networks, LSTM and BI-LSTM, expose the best regression accuracy at the end of genetic algorithm evolutionary iteration step. This network uses sequences of length 10, the sequence input, the LSTM dropout, BI-LSTM, and regression output. They differ mainly, and this other network uses sequences of length 30. So the same, more or less the same sequences, but of length 30. So sequence input, LSTM1, dropout, ReLU, BI LSTM, ReLU, LSTM, and regression output. The two architecture emerged as the best performances, LSTM and BI LSTM networks. They differ mainly in sequences length, showing that temporal context play a key role. When applied to healthy heartbeats, the RNN predicts future signals segments accurately. This results in a low RMSE, confirming that the model has learned the normal cardiac dynamics. So the input, then in the RNN we have the prediction. When we have input 2 and the RNN get us the predictions of the consequences. And then the third part of the signals, the RNN get us the predictions. Sorry, I do a lit. I have to. I have to pause for 2 minutes. Can I come back in 1 minute?
Yes, yes. No.
Okay. Okay, that was the execution example of an healthy heartbeat. So when applied to healthy heartbeat, the RNN predicts future signals segmentation accurately. The result of low RMSE, confirming that the model has learned normal cardiac dynamics. So this is an example of an unhealthy heartbeat. When the same model is applied to unhealthy heartbeats, prediction error increase significantly. This clear difference makes RMSEA an useful indicator of anomalies. So in our cases, we can detect the anomalies. For example, here in the anomalies, part, the RMSE is high. So the important part now is the localization of the anomalies. When the error highlights specific regions and those regions align with the physiologically meaningful portions of the beat, you get an explanation that the clinicians can inspect. Where it fails is equally instructive. Threshold can be unstable, noise can trigger false alarms, and patient variability can change the baseline. This is the signal domain equivalent for imaging failure analysis. Understand not just where the model is right, but what the model reacts to. So in our results suggest that PVC patterns tend to concentrate in specific regions of the cardiac cycle. This information is valuable not only for detection, but also for interpretability. So in preliminary results, we compute the RMSE for each test set acquisition, sample by sample, and then computed the mean RMSE for each sample. You can imagine a matrix of sides 7,000 per 61. For each column, we have a mean RMSE. Following these preliminary results, the PVC classes may rely from position 22 to position 27, and then from position 37 to position 44, in the middle and near the end of the heartbeat. The next step is explainability. We plan to highlight the ECG segment that contribute most to anomaly detection use XAI-style techniques. Clinical validation with cardiologists is essential to confirm these findings. So in the near future work, we converted the test set, so the 7,000 sample, into images and highlighted the ECG portions like Lyme, GradCam do, on which PVC classes should rely. This is how we use the explainable AI in the man-in-the-loop. So the goal is to understand if a real correlation exists between the predicted ECG PVC class portions and the real PVC classes. We actively seek help because we need a physician and cardiologist to complete this work. If you're interested, do not hesitate to write me to help us. And this dataset will be made public soon. So most of the computational time was wasted to the high death ratio. Large portion sites need high computational power to train the neural network. We pay the training overhead at the training startup, normalization, data preparation, and for every training. We use the MATLAB 22 for our experimentation. Also, this approach is computationally expensive due to the evolutionary process. Large portions and repeated training introduce significant overhead. Optimizing efficiency is a key direction for future work. So let's look back at our very first question. How to gain trust? In healthcare, trust is not a secondary concern. It is a prerequisite for adoption. Explainability and interpretability are key mechanisms to build this trust. Clinicians, patients, and institutions must be able to understand why a system produces a certain output, not just what the output is. With explainability, even highly accurate system may never be used in the real clinical settings. This slide provides a conceptual map of the explainability landscape in digital health. There are several important distinctions to keep in mind. First, we differentiate between interpretable or white box model and black box model. Second, explanation method can be global, describing overall model behavior, or local, explaining individual predictions. Finally, some XAI techniques are model agnostic, while others are more model specific. Understanding these dimensions help us choose the right explanation strategy for each clinical use case. White box models are inherently transparent, they are simple, easy to validate, and straightforward to communicate to clinicians and regulators. Examples include logistic regressions, generalized linear models, small decision trees, and clinical scoring system. These models are often preferred in healthcare when interpretability and accountability overweight raw predictive performance. However, their simplicity may limit performance or complex data, such as images or high-dimensional signals. Black box model, on the other hand, offer high predictive power, but at the cost of transparency. These include ensemble methods like random forest and gradient boosting, as well as deep neural network for images, signals, and electrode health records. While these models often archive state-of-the-art performance, their internal decision processes are opaque. This opacity creates challenges for trust validation and regulatory approval in clinical environment. Qua. The global explanator methods aim to describe how a model behaves overall. They help answer questions such as which features are most important and how does the model respond to changes in the input variable. Common techniques include feature importance, partial dependencies plots, ICE curves, and global SHAP summaries. These methods are particularly useful for model validation, auditing, and communication with institutions and regulations. Local explanation methods focus on individual prediction They answer questions like why was this specific patient classified in this way? Techniques such as LIME, local SHAP values, and counterfactual explanation are especially valuable at bedside. They support clinical decision making, patient communication, and shared responsibilities between human and AI. In the high stakes medical context, local explanations are often the missing link between AI output and real clinical trust. So, to conclude, through this talk, I have tried to show that applying AI to biomedical signals and medical imaging is not just a matter of improving accuracy or performance metrics. Clinical AI operates in the high-stake environments where errors have asymmetric costs and where trust, accountability, and interpretability are essential. Whether we deal with the medical images or physiological signals, the goal should never be to replace clinicians, but to support humans' expertise in a safe, transparent, and responsible way. Human in the loop approaches robustness to real world variability and explainability models are not optimal add-ons. They are core requirements for real clinic impact. I hope this overview has conveyed not only the technical challenges, but also the broader clinical and ethical perspective needed to design AI systems that can truly be adopted in healthcare. Thank you very much for your attention. I will be happy to take questions. And
Yeah, thank you, Dr. Paola. So now, yes, some questions are there. Okay.
Okay, she's the reason why I had to.
Yes, I know. Thank you very much. I know you are in maternity leave, and
yes,
after my request, you are eager to accept our request to join. Thank you. Now, who is going to give our answer? You are going to give the answer, or she is going to give the answer? Your daughter, or son. Your baby will give the answer, or you are able to give the answer?
I don't know. I don't know if I prefer if you would like to go in deep in this topic, we can talk about it by email. I can provide you my email and answer all the questions.
Okay, no
because
problem.
right now I'm a little bit
Okay. So Soumya, quickly ask the question, then we'll stop. 1 or 2 questions we'll take.
Wait. Okay.
Soumya. Yes, Soumya. Unmute yourself.
Hello.
Soumya, unmute yourself and ask.
Hello.
Yeah. Ask the question. Yes.
Good afternoon.
Yeah.
So I want to ask why we are using the relative MSE rather than MSE, as MSE is more easier to calculate than the RMSE. So can you explain it?
Because in the first study we have done, we compared the more metrics, and then we choose the RMSE.
No, so there is nothing more information just because the RMS is providing the more value, so we are taking it.
I can provide my email. I can explain.
Yes. All of you just do one thing. Write the query in the chat box so that I can give to Dr. Paola. So once she's will get back the answer, I will share with you. Okay.
Thank you very much.
Okay. Thank you, Dr. Paola. So you can take care of your baby. Thank you very much.
Oh,
so
thank you. I'm sorry.
Yeah.
And thanks again to inviting me.
No problem, Dr. Paola. Thank you very much. So later at 3 o'clock we'll join again. So any query is there in the group, you can write down. In the WhatsApp group also, I can share, talk with Paola to give the answer. Okay, thank you very much. We'll again join at 3 o'clock.